Welcome back for another episode of the School of Airway. Today we're going to talk about KSI, ketamine sequence induction, for the patient who you know has almost no uh, zone of safety. Like you can't intubate and you can't oxygenate for only a few seconds, up to 30 seconds. In less than a minute, the sats will plummet down. Right? No, not much room for error. This patient was morbidly obese, at least 420, 450. Chronically on BiPAP at night. But for the last 3 weeks, the daughter has been saying that the sats would be dropping to the 70s and 80s during her sleep, even while snoring and while connected to the device. For some reason, she decides to come in today and wants everything done for her mother. Her mother is in her 60s, arousable when you shake her, did a gas before BiPAP put on in the emergency room, and then again, unfortunately, her sats were maintained in the low 90s. That's tolerable, but the PaCO2 keeps rising. Of course, this would become a MICU consult, and I made a decision to intubate because the family decides and continues the daughter that she wants everything done. So, morbidly obese, I assume that this patient needs a maximization of positioning, oxygenation. Perfect. I have a supernova for her. And now I'm going to use a video laryngoscope. And instead of paralyzing her, I'm going to actually see how much she tolerates sedation-only intubation with ketamine. Alright? According to the order, she hasn't eaten anything for the last 12 hours. She's been lethargic all day, so I assume she hasn't eaten anything. Don't know if she has any history of gastroparesis. She is a diabetic, and which is attributed to chronic steroid use as per the daughter, because the patient has chronic bad COPD and asthma. Alright? And she's chronically on oxygen. So, I made a decision with the resident PGY2 that she's only going to get oxygenation through the Supernova. It's a new device for her, so I'm not going to use this nasal cannula and the face mask. I'm going to use the Supernova to keep her oxygenated. I had to position the patient correctly. Alright? I made a decision we're going to use ketamine only, but realize intact upper airway reflexes are going to mean possible bronchospasm, and also another sequela of ketamine, bronchorrhea. So we had to have our suction ready. Alright? Usually it's some nasty, thick, clear stuff that I don't know where it comes from, but it looks like alien sputum. Alright? Very sticky, in my experience in the past. So we had to have the suction ready. Alright? Made a decision to use a video laryngoscope. We're going to use the King System King Vision. Now at this time, right before we're about to use use the ET tube and preload this, I saw a little red light, and I saw a ringing sound, ding, ding, ding. So we gave the ketamine. Patient tolerated it. As I was about to enter the mouth, my resident was about to enter the mouth. Entering. Nice view. Cuts off. Blank screen. So luckily, I learned a lesson. Thankfully, we had the device on. Alright. Luckily, I was able to reattach the mouthpiece and keep their sats up with some bagging. Okay? Still has the ketamine in system. Alright? And we gave a high dose of ketamine for this lady. Right? We give like 200 milligrams. Alright? Big woman. Alright? Pushed it slowly. Alright? She weighs over 200 kilos. Alright? I gave the range of the 1 milligram per kilo. Alright? I didn't even try the 2 milligram per kilo dose. Alright? So then I had to find new batteries for this video laryngoscope. Alright? And then the respiratory therapist who had been there with a ventilator said, hey, don't you need this? So then the biggest rule of video laryngoscopy, despite how new it is and how awesome it is you should always have some backup to the intubation device. Not a blind intubation with the bougie by itself, but a direct laryngoscope. Alright, there's still a role for this. Alright, so change the batteries. Second attempt went in. A lot of copious secretions. Suction, suction, suction. Sats drop a little bit. Remember, we have not paralyzed this patient. We stopped the suctioning because when she's about to see the cords, a lot of secretions. Sats drop. We pull back out. Reattach the mouthpiece again. We oxygenate her up. Alright. And then get the sats up. This patient hasn't been paralyzed, but so far tolerating the device. Alright. So I really needed to get this device in. Alright. 3 strikes. My resident was already a little panicky because she didn't get the tube in. I was like, you know what? I'm going to get intubate this patient. Alright. I have my backup DL blade here. I have my suction ready. Alright. So, we hope for the best. Alright. Go in. Doesn't look that bad. The worst thing that could happen is I touch this. Closes up completely. Does not allow any passes of the ET tube. Alright. This is because I'm a novice, because usually all my patients are intubated with paralysis. So bronchospasm will not occur. Alright. So this was my maneuver. Barely able to fit. I lift weights. I try to be as strong as possible. I use all the force that I could get to pry it in. My head is turning purple. My veins are popping in my head. And I was able to slide this in. Alright. Barely. Then, with that, barely. Oh. The lesson learned is, with intact upper airway reflexes, you have to know that, alright, with intact upper airway reflexes, bronchospasm can occur. People like to blame ketamine. It could occur at any patient who's fully awake or even sedated and not paralyzed. Alright? Of course, I had the Sux and Vec or Rock ready, but I never thought of giving it. And in that time, I would have probably should have given it, and I learned on my Twitter world from my colleagues who I respect dearly in airway teaching. I should have just pushed it then. It would have allowed the paralysis of the cords, would have allowed the passage of the ET tube a lot easier and less stress on my part of trying to use my force and prying it in. I didn't use that painful stimulus from behind the ear, but I should have at the time. And this, of course, through surviving my mistakes and the patient surviving my mistakes, I learned to use this method of this painful spot right behind the ear, almost like the Vulcan pressure point that Spock would use. It doesn't include paralysis, but causes horrible pain, even in the unconscious patient. Sends a message to the area that also controls laryngospasm, and when it diminish it or inhibit it, and the bronchospasm probably would have been resolved, relieved, improved. If it hadn't, the paralysis medicines would have allowed the easier intubation. Okay? We confirmed with the end-tidal CO2 that it was in, and she survived my mistakes. And my resident survived my mistakes, and she learned as well. So, thankfully, she was able to get kept oxygenated with this modified new nasal CPAP face mask, the Supernova. But lessons to be learned. With DL is the backup to video laryngoscopy, and the backup to video laryngoscopy is DL. Okay? These devices run on batteries or are plugged next to the wall, so if there's no energy source, they're useless. Okay? Including the batteries to the DL blade. Alright? If you have intact upper airway reflexes, bronchospasm can happen. Not from just ketamine alone. Do not fall in that trap. Alright? Be aggressive with suctioning. Alright? KSIs for patients who think you can't tolerate too much inhibition of ventilation on a person who's hyperventilating for metabolic acidosis, severe metabolic acidosis, or the person whose sats cannot tolerate much apnea on the person who's has not much of a reserve, a functional residual capacity in this morbidly obese woman. All right, so just learn those lessons from Torres. I survived these lessons. Now I'm a lot wiser from experience and mistakes. Okay, so please come back for another episode of the School of Airway.